Good evening and welcome. I'm James Liu, and I'm a librarian at Stanford Health Library. Thank you for joining us. Our talk tonight is entitled The Vital Role of Cholesterol and Your Health. It's my pleasure to introduce our speaker, Dr. Randall Stafford. Dr. Stafford is a professor of medicine at the Stanford School of Medicine. He's also the director of the program on prevention outcomes and practices. He and his research team focus on investigating physicians and patient practices in order to create effective healthcare models that emphasize prevention and wellness rather than treatment of disease symptoms. His mission is to improve population health outcomes through research that facilitates the development and broad dissemination of effective, efficient, innovative, and evidence-based prevention strategy. Throughout the talk, please enter any questions in the Q&A box at the bottom of your screen. At the end of the talk, Dr. Stafford will answer as many of those as possible. Dr. Stafford, I'll turn it over to you.
Thank you so much, James, and let's get started here. So first of all, I want to welcome all of you to the talk today. It's great to be with you. And I'm going to be talking about know your cholesterol. How does your cholesterol fit into your prevention profile? I am a professor of medicine within the Stanford Preventive Research Center and have many years experience both in clinical practice around prevention, as well as research in the practice of prevention and the evidence behind prevention. So just to kind of outline what I'm going to be talking about, I'm first going to try to give some background information about understanding your cholesterol results. And to make it clear that lipids are a potent risk factor for coronary artery disease as well as stroke, and that we have strategies to improve lipids, including those involving drugs, as well as non-drug strategies. Lipids can also be a marker for other diseases, particularly diabetes. And I want to bring us back to this idea that cholesterol and lipids are only one of many risk factors for cardiometabolic disease, including heart attack, stroke, and diabetes. I'm going to provide a comprehensive primary care perspective. And my goal really is to provide some key practical information you can use. Now, I do want to provide a couple of caveats. First of all, there may be clinical issues which really have the necessity of a dialogue with your own physician. So I'm not going to be getting into the details of what we would do in any particular situation. I'm going to talk on a very general level. And then second of all, with the population that we have in the audience, there's a vast spectrum of people's initial knowledge about cholesterol and lipids. And I know that there are people here who probably know more than I do about lipoprotein chemistry. And my goal isn't necessarily to bring you up to date with the latest and the greatest on topics around lipids, but really to provide information that's really practical when you meet with your doctor. So my main take-home messages, first of all, to just always remember that cholesterol measures influence your risk of cardiovascular disease, principally stroke and heart attack. The use of lipid ratios, and I'll get into this in a bit, may be the most useful way of looking at your cholesterol results. And then fasting before lab testing is much less important than it used to be. And I'll go into some detail on this as well. And I want to make it clear that health behaviors can impact both lipids and other risk factors for cardiovascular disease. And those other risk factors also deserve your attention. And then finally, statins are a very proven strategy for improving lipids, but we need to combine strategies with drugs with what's known about non-drug strategies, particularly in the area of changing health behaviors. So let's get into a little bit of information here about how to interpret your results. So here's a panel of cholesterol results, and you yourselves may have had something like this. These represent somebody who has relatively healthy lipids, and we'll go into the reasons for that. But let me just introduce you to some of the abbreviations here, because this can be a little bit daunting. You know, when we say total cholesterol, we're talking about all of the cholesterol molecules that are floating around in the blood and measuring them on the basis of their weight per volume. Now, the total cholesterol can be subdivided into multiple different fractions or different types of cholesterol. And the first one we really focus on is the LDL cholesterol, which stands for low density lipoprotein cholesterol. This is part of the bad cholesterol. And we'll get into a little more detail about what it means to be in these lipoprotein molecules or aggregates. But LDL cholesterol is one component of the total cholesterol, as is HDL, which is often called the good cholesterol. HDL stands for high density lipoprotein cholesterol. And then things get just a little bit complicated because we report something called triglycerides. And when we report that value, we know that there are cholesterol molecules within or that travel along with triglycerides. Triglycerides are basically fats. But the triglyceride value that we get on the lab results doesn't add up to the total cholesterol, simply because it represents a larger weight of cholesterol or cholesterol carrying molecules in the bloodstream. And then we need to talk about this idea of non-HDL cholesterol. So if we subtract the HDL cholesterol from the total, we get what's often called the non-HDL cholesterol. And this is really the aggregate of the bad cholesterol floating in our bloodstream. It's made up of the LDL plus part of this triglyceride measurement here. Another ratio is the cholesterol to HDL and also the LDL to HDL. Now, these are simple fractions of taking our ratios, taking the total cholesterol and dividing it by the HDL cholesterol. You'll see here that I've not only listed the results, but typically results will come with what's called the normal range. And I'll talk about this a little bit, but in general, this idea of a normal range isn't particularly useful. And in general, you really need to understand all of the cholesterol results together and not pay too much attention to whether a particular value is within this normal range. And you can see here that by and large, the values that are reported are within that normal range. Now, if this person were extremely high risk, had a heart attack, I would no longer consider some of these values normal or desirable. And we do have this one test, the triglycerides, which is above the normal value. So we'll discuss this a little bit further as we go along. When we talk about lipids, we know that these can vary considerably from person to person. And here's an example of sort of an unusual situation of somebody with liver failure. The liver is an organ that's responsible for putting together these cholesterol aggregates, these molecules that aggregate cholesterol and protein and other types of molecules into a packet so they can circulate in the bloodstream. One of the key messages is that cholesterol is a molecule that is not soluble in water, it does not dissolve in water. Left on its own, it can't travel in the bloodstream. That is, it's like oil and vinegar. It would separate. So the body has devised or evolved to carry cholesterol in these aggregates that hold the cholesterol, in essence, in the middle of other molecules so that it can travel within the bloodstream. So in this case, this individual, a young guy, has liver failure, and his liver is not able to manufacture and to put together these molecules that we're measuring here. And you can see that most of the values are actually quite low. On the other hand, here's somebody who has prediabetes who is taking a lipid lowering medicine called the atorvastatin. But you can see that the values are quite a bit higher than over here, and that there are some particular issues, particularly with the low level of HDL and the high level of triglycerides. So what I've hoped to do with these first few slides is to give you a little bit more information about how to look at those results. And we'll get into further details about interpretation. Before I do that, I want to just talk about some of the relationships that exist between these different numbers in the results. So I did mention that the bad cholesterol is really both the LDL cholesterol and the triglycerides. The good cholesterol, as I said, was the HDL cholesterol. Multiple lipid test values are important. You can't look at one item on that lab result sheet and make interpretations. You really need to take all of those values together and know how to think about them. And one of the ways that I think about these results is by using these lipid ratios. And I introduced this previously, and we'll hear a little bit more about that in a moment. It's important to realize that total cholesterol increases both with LDL, the bad cholesterol, and with HDL, the good cholesterol. So what this means is that total cholesterol in and of itself may not be such a useful lab test. And looking at these different components of total cholesterol is really where it's at. And then I also want to make this point that lower HDL correlates with higher levels of triglycerides. And this is a pattern that often is called insulin resistance, goes along with prediabetes and diabetes. And then finally, as I said before, this idea of normal values has some utility, but it's really a limited concept because we think about cholesterol much differently today than we did 50 years ago. And this idea of normal values is really, in some sense, an antiquated holdover. So one of the practical issues that comes up for me and my patients is whether fasting is truly needed. So part of this has to do with this idea of calculated versus measured LDL. Usually, total cholesterol, HDL, and triglycerides are the things that are measured by specific instruments in the chemistry laboratory. And then these indirectly are used to make an estimate of the LDL level. Now, it's also possible to directly measure LDL, but it is more expensive. A panel blood test with a calculated LDL, is about half the price of one with the directly measured LDL. Now, I admit these are small numbers when it comes to thinking about healthcare and, surgeries that are costing $50,000 to $100,000. On the other hand, this is a very common test. It probably should be even used more than it is today. So even this difference of $30 or $39 can add up on a national level. And there were some past problems where the calculated LDL often didn't match the direct LDL when a particular type of formula, that is a particular way of taking these measured values and estimating LDL. But more recently, We have a new formula implemented by the National Institutes of Health, which actually is a much better formula. And so with this new formula, it takes away two things. First of all, we don't need to necessarily measure LDL directly because it doesn't help provide much more accuracy. And then secondly, we don't necessarily need to be fasting. And part of the problem with the old formula, it was particularly affected by large fatty meals. And this means that, there are limited advantages of using the direct measurement and having the patient fast. So in some ways, this is a pretty big shift over the last 5 years or so. We're no longer advocating on a routine basis to do fasting cholesterol tests, although for some patients, it may be more useful to get that fasting level. Well, I wanted to, give you a little bit of an illustration of these different lipid particles. And again, the idea is that cholesterol is a very important molecule in the body. It is part of cell membranes. It really has a lot to do with the integrity of cells and the signaling between the outside of a cell and the inside of a cell. And so we need cholesterol, absolutely. And the cholesterol that's circulating in our bloodstream has to circulate via these different particles. And we basically split these particles up into the good and the bad particles. And within the good category, we have a couple different versions of high density lipoprotein. And you can see here that this is a scale of density, with density getting greater. That is, the amount of weight per a particular volume is getting greater as we go downward. HDL are the most dense molecules or aggregates. And water, of course, has a density of 1. Blood itself, because of some of the fats that travel in blood, is just a little bit less than 1. So it's about here. So in other words, if we think about blood or water, these things sink and these things float. So the good cholesterol, HDL, bad cholesterol is made up of the LDL family, as well as these bigger aggregates that include more fats. And in all cases, you can see that the cholesterol is actually kind of encased within other molecules so that it doesn't actually have contact with the solution of the blood, with the water-based nature of blood. So this is how we kind of split up these molecules by their density, how heavy they are for a particular size. And I just wanted to talk a little bit about kind of this link between high cholesterol, particularly high LDL cholesterol, and what happens within blood vessels, particularly arteries. So in the middle here, we have the blood vessel with the outside and the inside of the blood vessel. And this is a very healthy artery. You'll notice that there's really no deposits going on here. And this contrasts with a very diseased, partly blocked artery that has this deposit of mostly cholesterol within it. And a very simplistic, perhaps, way of thinking about it is that LDL cholesterol pushes cholesterol into the lining of the blood vessel. HDL, in some sense, extracts cholesterol from the lining of blood vessels. Now, this is a bad thing because a couple of things can happen. If this artery gets blocked more completely, it can reduce the ability of that artery to carry blood, and the blood flow to whatever organ is being served by this blood vessel is reduced. And that's a particularly bad thing within the heart. And that is often called angina, chest pain that results from these arteries serving the heart with blood being partially or completely blocked. A heart attack, on the other hand, also results from these big deposits of cholesterol, but has to do with a rupture where this amount of cholesterol bursts open into the inner part of the blood vessel and then initiates a process that forms a blood clot. When that blood clot forms, it basically prevents that artery from carrying blood downstream. And if that downstream blood is serving the heart, then the heart has no oxygen, no nutrients, and part of the heart essentially dies and scars if a heart attack occurs and is not immediately reversed. So I wanted to talk a little bit more about these ratios. And part of the idea here is that any one value doesn't really tell us that much about what's going on. It doesn't tell us that much about risk. But by putting together two different types of HDL, we can get a better result. So in this case, again, what we're talking about is a numeric ratio between the LDL cholesterol and the HDL cholesterol. And so what we have here is the bad cholesterol on top, the good cholesterol on the bottom. As LDL goes up, this ratio goes up, and that's bad for you. On the other hand, if HDL in the denominator here goes up, then the ratio goes down. So that's good for you. So this is a way of putting together two different lab tests to kind of give us a better sense of the overall issue with the cholesterol tests. And it balances the idea of good and bad cholesterol levels. And again, these two components are part of total cholesterol, which is why total itself may not be a very reliable measure. And total to HDL cholesterol is sometimes also calculated. This is similar, but not quite as reliable as LDL divided by HDL. And then another important ratio is triglycerides divided by HDL. And again, here we have triglycerides on the top. If they increase, the ratio is increased, which is bad for you. If HDL increases, this ratio goes down, which is good for you. This is a particularly important proxy for insulin resistance. That is the process that can go on to cause both prediabetes and diabetes. It's also a proxy for the size of the LDL particles. And what we know is the more particles we have floating around in our bloodstream, we have an increased risk of atherosclerosis. That is that process of depositing cholesterol within the lining of the arteries. And if we have smaller particles, that means we have more particles floating around for a given LDL level. Again, remember that the LDL level is measured as a weight, a component of weight within the bloodstream. And just a little more information here about how lipids are a risk factor for atherosclerosis. We have these very important arteries. In some sense, people could say they're the most important arteries because we can't function without our heart. And these arteries, which start both as a right coronary artery and a left coronary artery, go on to branch and serve the whole heart muscle with oxygen and nutrients. If one of these is blocked, that's really bad news. And these arteries are particularly susceptible to that process of cholesterol being deposited within the lining of those blood vessels. So when we have increased LDL and triglycerides, we have cholesterol deposits, we have the narrowing of those arteries, as within angina, the potential formation of blood clots if those cholesterol it ruptures into the blood vessel. And this is not just in the heart. the heart is kind of the most important example of atherosclerosis, but in some sense, this is occurring in almost every single artery of the body. It's just that the heart is much more vulnerable than some other organs. And of course, the other susceptible organ is the brain. And the same process that we talk about causing a heart attack, similarly, when involving blood vessels serving the brain, results in what we call a stroke. Again, the formation of a clot that keeps part of the brain from getting the blood flow that it really needs. I want to introduce this idea of prediction models. And this is a way of taking the results of the cholesterol tests and making sense of them in terms of how they actually change one's risk of having a heart attack, of having a stroke. So what I've done is basically put in my own information here. I've made myself a little bit younger so that I could show you something very specific. But when I calculate this for myself, I get this number of about 6.5%. And what this means is that over the next 10 years, based on these risk factors, including my LDL, my HDL, and my total cholesterol, I have a 6.5% chance of having either a stroke or a heart attack. And this compares to what we call the optimal risk. So if all these risk factors were their lowest possible values, my risk would be a little bit lower than it is. You know, if my total cholesterol was a little bit lower and my HDL was a little bit higher, if my blood pressure was a little bit lower, then this could go down to a minimum of 5.2. So it's not too far off. Now, what I want to, and then one last item is that this prediction model, and you can find it here or simply Google search for ASCVD risk estimator. It also provides an estimate of what's my lifetime risk. That is, at some point in the future within my life, having a heart attack or stroke. And it's about 50%. And that's no surprise because this is the leading cause of death in the United States. And it only makes sense that there's a certain limit to how low you can make that. And in my case, it's about 50%. Now, what I want to illustrate now is to take these values and change some of the cholesterol values. So I do that. And you can see here that I've changed the 85 to 120. I've changed the 62 from good cholesterol to 45. And when I make that change, instead of 6.5, I now get 9.7%. So almost a 1 in 10 chance that I will have a heart attack or a stroke if my cholesterol values were this. So one way of thinking about it, because my values are here, I've reduced my risk by about a third. So 6.5 compared to 9.7. Interestingly, my lifetime risk stays about the same at 50%. So this is a way of putting the cholesterol values in the context of an estimate of how much risk there is that you're going to have a heart attack or stroke. And I really encourage people to look at this and discuss the results with your doctor. So now that we have understood a little bit more about what these test results mean, let's say that the lipid levels are high. What are the reasons for that? Well, there are a bunch of non-modifiable factors that change lipid levels. So by sex and gender, women generally have higher HDL. And women generally have lower levels of LDL, triglycerides, and total cholesterol, at least under the age of 50. And some of this shift is very likely hormonal before and after menopause in terms of these gender differences. We also know that many of these parts of bad cholesterol and in fact good cholesterol, they all increase with age. These ones up until the age of 50 and HDL particularly after the age of 50. Now, another part of this is that different ethnicities and race, both for genetic and for social causes, seem to have different levels of some of these cholesterol. So HDL is often higher in people of African descent. And at the same time, LDL and triglyceride tend to be higher for Latinos compared to whites, Asians, or Blacks. And I want to make the point that, particularly within Latinos and Asians, they are not homogeneous populations, and different Asian subgroups may have very different risks of heart disease and of high cholesterol. Let's talk about other reasons. So it's very important to recognize that health behaviors alter lipid values. And dietary practices that are recommended to lower cholesterol involve less saturated fats, eliminating trans fats, and reducing cholesterol. It's also equally as important to really focus on increasing fibrous vegetables, whole grains, and plant-based fats. And then it's also important to reduce the amount of processed or simple carbohydrates that we have in our diet. These are things that, unfortunately, very few of us really attain a diet that meets with these recommendations. And on a national level, the current diet of the American population does contribute substantially to higher cholesterol levels and greater risk of heart disease and stroke. Important other factors are physical activity, which can improve insulin resistance and at the same time increase the good cholesterol and lower triglycerides. And weight loss can improve insulin resistance. So these are very important types of strategies for lowering cholesterol. And of course, if one thinks about why someone may have a high level of LDL or triglycerides, it's important to look at these sort of health behaviors to perhaps understand a little bit of how they got there. Now, it's also important to recognize that there are genetics involved. Your risk of having high cholesterol and being at higher risk of a heart attack or stroke may well be familial. It may be something that you've had the genes for a particular pattern passed down to you. I also wanted to point out that while alcohol does improve HDL and LDL, it's really important not to fall for the myth that alcohol is beneficial. Even with these benefits in terms of cholesterol, the harms that alcohol has in terms of accidents, cancer, increased cancer risk, and its interaction with mental health and other substances really means that the net effect of alcohol is negative. That is, it harms us much more than it benefits us. And unfortunately, I think many Americans continue to believe a myth that somehow low level of alcohol intake is beneficial. I think we really are quickly moving away from this. But, in terms of public information, I really feel like enough is not said about this topic. Let's talk a little bit about drugs, particularly statins. Statins are one of the most well-proven drugs for lowering risk of heart attack and stroke. And there is this long list of different chemicals, different drugs. The one that's used the most in the United States is atorvastatin. It used to be called Lipitor before it went off patent. Its generic name is atorvastatin. And what we see here is this idea that different doses of different drugs can result in either low intensity, moderate intensity, or high intensity. And generally, people with known coronary artery disease or who have had a past stroke should be on high intensity statin therapy. Now, there are other drugs that lower cholesterol. In my mind, these are often a second line treatment. If statins work and if statins are tolerated, statins are the best drug. If statins are not tolerated, and there is a fraction of people who have problems with muscle aches and muscle inflammation, even from statins, where statins are not a good idea. But for the average person, statins are a very well proven strategy. Now, I will say that even though they are well proven, there are some areas where the proof is not necessarily as strong as I might like it. So the best evidence is for the effect of statins on middle-aged men. And when it comes to some other populations, particularly older women, let's say above the age of 75, we really have less information than we should to really guide kind of evidence-based practice in that area. In my mind, that doesn't mean that there are no benefits. It just means that we are less certain. We're less certain of that proof than we are with, let's say, middle-aged men. And so let's talk a little, let's talk a little bit about the impact of statin therapy. So we have a before set of lipid values. And this is prior to somebody beginning a statin. And you can see here that part of the rationale for a statin is we have a high LDL cholesterol. You know, whether we're looking at it in terms of this normal range, it's well above the normal range, or if we think about, let's say, this useful ratio of LDL to HDL, it's well above what we would like to see. So this person gets started on a statin, and here are the results several months later. Oops. Okay, there we go. So we'll see that the total cholesterol is reduced. The LDL in particular is reduced. And these are a real patient in my clinic. The HDL is slightly increased. Often we do see this increase in HDL, which is kind of a secondary benefit of statins. So they're not only lowering the LDL, they're raising HDL, and often are lowering the triglycerides as well, which we see in this particular patient. If we look at some of these other ways of thinking about cholesterol, you'll see this very large reduction in non-HDL cholesterol. And you'll see this big change, particularly in this LDL to HDL ratio, where we have it moving from 3.8 to 2.1. I'm going to move along a little faster simply because I want to make sure I cover a couple other topics. But I do want to make this point that the way we think about statins has changed. In the old days, we used to say, well, we have this normal value. We want this person to have a LDL cholesterol below 130. Well, we'll use a statin and we'll increase the dose of that statin until we get what we need, until we lower the LDL below that particular goal. These days, we really use this idea that higher risk individuals should be on a statin of high intensity, which means either one of two drugs, atorvastatin, Lipitor, or rosuvastatin, used to be called Crestor. And that people who don't have that high risk could be on a low intensity or moderate intensity, depending on exactly what their risk factors are, depending on how high that percentage is that I calculated using the risk estimator. So I do want to just emphasize that lipids are only one of many risk factors for CVD risk, for having a heart attack or stroke. Smoking is among the most potent factors. And one thing that I always tell my patients is, if you're smoking, we're kind of wasting our time fiddling around with cholesterol and cholesterol lowering drugs. The most important thing for your health is going to be to quit smoking. Similarly, high blood pressure is also part of one of these risk factors. And unfortunately, it's become so common that really a majority of Americans have a blood pressure that's too high. Diabetes and prediabetes are also linked to higher rates of stroke and heart attack. And we have a population that also tends to be overweight. And weight management, including maintaining a healthy weight or losing even 5% of your weight, can be a very important way of reducing the risk of heart attack and stroke. Similarly, physical activity, probably the number one most effective prevention strategy. You know, if the drug companies had a way of packaging this, this would sell so much better and would be so much more effective and cost effective compared to other drugs that we have or other strategies that we have. Adequate sleep, social networks, and having better stress coping mechanisms. These are all kind of up and coming risk factors that we ought to be paying attention to, even while we focus on the main ones of smoking, high blood pressure, diabetes, weight management, physical activity, as well as cholesterol. And then finally, you know, I want to bring up this idea of systemic inflammation. This may be a key mechanism that underlies many of these different risk factors that is the linkage between these risk factors, let's say smoking or high blood pressure, and the developing a high risk for heart disease or stroke. So I also want to get across this idea of a comprehensive approach. You know, we want the intensity of our prevention strategies to be calibrated by the benefits we gain. So again, if someone's smoking, the greatest benefit is really going to be gained by quitting smoking, not reducing, let's say, the LDL cholesterol by 20%. There's also the synergy of addressing multiple risk factors at the same time. And, you know, we shouldn't necessarily focus just on a single risk factor like cholesterol without considering this larger picture. And, you know, again, one of the issues is that in some ways, cholesterol is an easier risk factor to think about and to manage compared to like smoking or high blood pressure. But if our blood pressure is way too high and we continue to smoke, then, you know, the ease of managing cholesterol doesn't necessarily pay off. And we ought to be spending more effort on risk factors that can make a bigger difference. So in summary, just wanted to emphasize this idea of lipids being a risk factor for the deposition of cholesterol into arteries. The use of the LDL-HDL ratio, I think, is a really good way of thinking about the test results rather than looking at any particular number. Using the TG or triglyceride HDL ratio is really a good index of metabolic problems. And again, those metabolic problems are ubiquitous within the United States and other developed countries. This is particularly useful because it is this indicator of insulin resistance, that is prediabetes and diabetes. Fasting may not be needed for testing, and this is, again, different than things were a decade ago. And multiple health behaviors affect lipids. And in some ways, this is the best approach. If you can reduce cholesterol through changing health behaviors, there's no doubt that this is optimal. On the other hand, statins are an effective strategy. They do reduce cholesterol. They do reduce the risk of having a stroke and heart attack. But all these risk factors and all these strategies really should be considered at the same time in a comprehensive approach. So that's all I had to say. And I'm going to welcome you to put in your questions into the Q&A portion of the webinar. And I already have a few questions that were sent in ahead of time. Okay, so one of the questions was the idea of how processed or unprocessed carbohydrates affect cholesterol. And this whole question really reflects this idea that our diet is made up of these major macronutrients: protein, fats, and carbohydrates. And in the past, we tended to think about all fats kind of together and all carbohydrates together. And within more recent history, this has become more nuanced. And it's very important to recognize that there can be good fats and bad fats. That's largely on the basis of plant-based fats being better than the fats of terrestrial animals, animals living on land. Marine animals have a type of pattern of their fat and cholesterol, which actually is quite beneficial. And this is the whole idea of fish oil. Now, fish oil probably doesn't have the benefits that were touted a decade ago. Some more recent studies have cast some doubt on the magnitude of their impact. But there are some individuals, particularly individuals with high triglyceride levels, who may substantially benefit from eating more marine animals like fish or crustaceans, or taking fish oil as a supplement. So that's the fat side of things. When we talk about carbohydrates, we really can think about how complex the packaging of a carbohydrate is. So if we are talking about sugar, which is a type of carbohydrate, when we ingest sugar, that sugar gets into our bloodstream very readily. It basically, our body splits a sucrose molecule in half, yielding a smaller sugar molecule that is then absorbed into our system. That is in some sense, the worst type of carbohydrate. On the other end of the spectrum are the carbohydrates found within fibrous vegetables. So something like broccoli has plenty of carbohydrate, but the way it's packaged is with a lot of fiber, with very long, complex carbohydrate chains. And the fact is that both mechanically in terms of chewing and enzymatically in terms of digestion by enzymes, our body is much slower to take a complex carbohydrate and get out of it the sugar that eventually is going to circulate in our bloodstream. So the question about processed versus unprocessed really has to do with the complexity of the carbohydrates. And this idea of processed carbohydrates or simple carbohydrates are bad in large part because they get into our bloodstream so readily. And that causes metabolic effects that are detrimental. On the other hand, complex or unprocessed carbohydrates tend to be absorbed and digested much more slowly and don't have that same forceful, abrupt impact on our metabolic system. So again, the idea is carbohydrates are not all the same. We need to make this distinction based on their complexity, trying to reduce or avoid simple processed carbohydrates and eat more complex carbohydrates. I have another question here about lab testing. How often? So some of this depends on the particular situation. If one is newly started on a statin, it's generally recommended to check the cholesterol levels 2 to 3 months later. if your cholesterol levels have been stable, have been at a healthy level, either with or without the help of a statin, then it really isn't necessary to check them all that often. And I would generally say that, checking them every other year might be very reasonable. Now, some doctors tend to check them every year. It's probably not necessary because in general, unless there are things like a reduction in exercise or gaining a lot of weight, it's pretty unlikely that the lipid values, the lab tests, are going to change a lot. But if there are changes such as I described, then maybe it's worthwhile testing the cholesterol values more often. For people who are at higher risk, for instance, somebody who has survived a heart attack, that's another instance where more frequent testing may be logical. I'm going to look through the multiple questions we have here. So there was a question about, on the panel, there's something called VLDL, which is very low density lipoprotein. So this is essentially the portion of cholesterol that's carried along with triglycerides. And if we remember that chart, these are the really big aggregates that float, that are less dense than water. And so the VLDL is another component of the total cholesterol. And in fact, LDL plus HDL plus VLDL does in fact add up to total cholesterol. Just to kind of reinforce something I said before, even though HDL and LDL are these aggregates that contain cholesterol and have that similarity, they are made up of protein, cholesterol, and fats. Even though they have that similar composition, they are much different from one another. And again, as I said, and this is, perhaps a little bit simplistic, but HDL tends to have a function of drawing cholesterol out of the lining of blood vessels, where HDL and high levels of HDL tend to force cholesterol into the lining of blood vessels. So again, despite the similarities of these two types of cholesterols, they actually act almost in opposite ways within the body. There's a question about how long to take statin medications. And again, in usual practice these days, in contrast to how we practiced in the past, it's generally thought that the best thing to do is to match a level of statin intensity with the risk of a person. So if someone's at very high risk, let's say has had a heart attack, they should be treated with high intensity statins for the rest of their life. And similarly, if we make a decision to start a statin in somebody at low risk and use a low intensity statin dose, similarly, unless there are problems tolerating the statin, that's something that I would expect to continue for the rest of someone's life. Another question is about the use of a heart scan. A heart scan is a type of CT scan, that's computed tomography, which uses X-rays to come up with a depiction of a cross-section of a portion of the body. And this particular technology can be used on the heart to look for the deposition of calcium within the arteries of the heart. And we know that where there is calcium, there's also the deposition of cholesterol. And so there are strategies to add to the risk equations, the risk estimators, by including a value for this calcium heart scan. Even if somebody had lots of risk factors and their calcium in their heart scan was 0, that might make me think, well, this person doesn't need statins nearly as much as another person. So this is another technology that isn't kind of standard of practice, but can be used, particularly to clarify whether to use a statin and at what intensity to use a statin, where things may be a little unclear. In general, it's not a go-to test for me, but there are some instances where it may be very helpful to try to get a better idea of what a person's risk is by looking for calcium in the arteries of the heart. And then just one other comment about inflammation. So I mentioned that for many of the known risk factors for stroke and heart attack, there seems to be a pattern that a certain behavior or a certain exposure, let's say to smoking or to alcohol, increases inflammation. What we mean by inflammation is abnormal activation of our immune system. Our immune systems are very finely tuned to be able to recognize and eliminate outside microorganisms. So the immune system has evolved to be very good at keeping things out of our system. The problem is that immune activation can also have a bad effect on our body if it gets out of control. And things like high blood pressure, increased weight, smoking, alcohol, diabetes, all seem to have an effect of increasing systemic activation of the immune system, which in turn likely increases the likelihood of heart disease developing. And one could think about this, for instance, at the microscopic level. If the lining of an artery is inflamed and is, in some sense like burned, the equivalent of an outside burn, then it may be more likely that cholesterol is going to be deposited at those parts that are inflamed. So this is something that's relatively new, but I think it's a really helpful way of thinking about these risk factors, because quite often the way we've thought about this in the past is, well, we have these risk factors here, and we know that they cause this set of outcomes like heart attack or stroke, but we haven't necessarily always connected the dots between them. So I'm going to finish there. I very much appreciate all of the questions that have come in, and certainly appreciate your attention. It's been great to talk with you. I regret that I haven't been able to get to all of the great questions that you guys asked me to. And if you have further questions for me, please email me. It's rstafford@stanford.edu. It's been great talking with you, and I'm going to hand things over to James.
Thank you, Dr. Stafford, for sharing this great information. And thanks to our audience for joining us and for the great questions. If you would like additional information or resources, please contact the Stanford Health Library. We hope you join us for our next lecture. Good night.